Well, thank you very much for coming to our clinic today, and it is my privilege to be here to help explain some of the changes in the healthcare system. Let me explain why do we need patient-centered medical home before I explain what is patient-centered medical home. If you go back in time to the 1970s, 1980s, the most common medical problems that we faced were infectious disease, was sore throat, pneumonias, somebody break their legs, son gets sick. So they were mostly infectious disease problem. That was the most predominant. So the system at that time was built on episodic care. The patient comes to see the doctor, they pays for that visit. It takes 2 to 3 days for the patient to heal, and then the patient is doing great. It takes months, and then something comes up, go see the doctor again. They see the doctor, they pay for the visit, and then they heal. They go home. So that's the system that we lived in for the past 20, 30 years. It's episodic. And the patient used to pay for the doctor, either money, either in other forms. And it changed to insurance companies. Then Medicare came in, started to pay for patients' visits. Now, over time, the kind of medical problems that we face as a nation have changed. Now, because we are very good in medicine, patients are living for a longer time. If you look at the average age in the 70s versus average age in the 2010, it has increased. So the average age of the patient is increasing because we're doing great in medicine. We are preventing people from dying from strokes and heart attack and emphysema. We have a lot of medicine that keeps patients doing good with these kind of problems. Now, the problem is that now we're facing a different kind of health problems. We're facing patients who have illnesses that live with them all the time. Patients who have osteoarthritis that's with them on Saturday, on Sunday, on Monday. It's with them when they see the doctor in March, and it's with them in June when they're not seeing the doctor. Same thing for diabetes. Diabetes is with the patient all the time. Heart disease and heart failure, it's with the patient all the time. But the healthcare system has not changed. We still have diabetes. We live with diabetes all the time, but we see the doctor every 4 to 6 months. Sometimes we forgot to see the doctor. Sometimes we forgot our medicines. But we're still treating the patients episodically. The patient's need has changed. We need to take care of the patient continuously, not episodically. So over the past 10 years, the healthcare systems have been thinking, so what do we need to change in the system so that we can take care of the patient who have chronic medical problems that's with the patient day and night, all day of the week, every month of the year. And there's where the concept of patient-centered medical home came from, to change the thinking from episodic care to a continuous care. And the other problems in the healthcare system is so the other problem in the healthcare system is that when the patient goes to the hospital, there's a medical record in the hospital. The patient leaves the hospital, go to the clinic, that information does not go back to the doctor in the clinic. So the information does not flow between organizations. That's what we have, silos. You go to the patient, you have medical record in the hospital, different than the clinic. That's why our healthcare is fragmented. And the way we pay for the doctors right now, we pay them episodically. So there's no incentives for the doctor to go and coordinate care from multiple places. So this is where patient-centered medical home came from. So what is patient-centered medical home? This is the definition. Patient-centered medical home puts the patient at the center of care, and it provides a primary care that is accessible, means you get to see the doctor either physically or by phone or by email, so the doctor is accessible and his team is accessible to you. Continuous, not episodic. Comprehensive, which means takes care of the whole patient. Family-centered, which means we engage the patient and their family. Coordinated and compassionate. So this is a representation of the patient-centered medical home. So the payment, instead of paying the doctors based on the visit, the 15 minutes visit, it comes a payment for quality of the care of the patient. So that's what's going to be the driver for us and health organization to change. access, which means the patient should have some form of communication with their providers. It could be physically, but it also should be through phone, through emails. Every patient is associated with a personal physician, and the physician will direct the practice. So there are multiple people involved in the care. Now we associate patient to physician, but the physician's care is going to become physician with mid-level provider, with the nurse practitioner, and everybody is doing part of the care. But all of them is under the direction of a physician. We approach the patient from all perspectives, not just one disease. Care is coordinated between hospitals and between physicians. Especially we have multiple specialties right now, so the primary care physician and his team needs to know what's happening when the patient goes see somebody else. And ultimately, we're going to provide quality and safety for the patient. This is another nice picture. It depicts the same information. So it's enhanced access to make sure that the patients have access to their physician and his team. We as providers, we have to identify the patients we are taking care of. The 500 diabetic patients, the 250 heart disease patients, we need to have them in a list, know what they're doing and what they're taking, and proactively manage their care. Which means even if the patient is not the clinic, we have a team that look at Mrs. Wells, did she have her diabetes test? If there's a red box here that shows that Mrs. Wells did not have her hemoglobin A1C and Mrs. Wells have not shown up to the clinic, we'll give her a call. Good morning, Mrs. Wells, you need your lab test to be done. So this is a proactive care. It can be applied to the same thing for medication. If we know that Mr. Jones needs aspirin for heart disease, and this list of our patient, we know that Mr. Jones is not on aspirin, we'll give him a call. So this is a planned proactive care. Provide self-care and community support. Because the patient comes to the doctor twice or 3 times per year, because there is a new medical problems, multiple medical problems, we need to educate the patient about what they need to know about their disease. At what point they need to call the doctor. We don't want to wait to get to late in the stage of the problem to call us. Example, a patient with heart failure. The moment the patient starts having swelling in their legs, they'll give the doctor a call. We don't have to wait until the legs are too swollen. By that time, they need to go to the hospital. So this is a simple way you can prevent an admission to the hospital for congestive heart failure. This is pain to the patient, pain to the family, and too much money for the system, and too much money for the patient. So if we can teach the patients about what are the early signs that you need to call your doctor, everybody is a win-win. Less money to the system, less money to the patient, more cost saving to the patient, and less pain to the patient. Track and coordinate, this is something that when we as a clinic and as doctor order a test, we want to make sure that the test is done. Multiple times we order a test and the patient does not do it. Not intentionally. It could be the patient forgot, the patient did not have a ride that morning, the communication between the patient and the doctor was not adequate, so the patient does not remember. So there are multiple causes why when we order a test, the test does not get done. So it's in the patient-centered medical home, we have to track what we've done to make sure it's being done. Measure and improve. Is the number 1, 2, 3, 4, 5 causing improvement? Is it resulting in better care and better satisfaction? Because that's the ultimate goal here, to make the patient more satisfied and more healthy. So we need to measure it. Template for the future, this is expanding it from primary care to hopefully in the specialty in the future. So what are the benefits? Better quality. Hopefully we will have fewer emergency room visits, fewer hospital admissions, better preventive care services, immunizations, mammograms, better care for chronic diseases, and higher patient satisfaction. What are the more benefits? There is less cost to patients and the system because there will be less unnecessary tests and less duplications of tests. So this is the patient-centered medical home. I usually draw pictures, so let me draw the picture here of this is how I remember it, and hopefully I can. So you have a patients have access to the clinic. Here the doctor and the patient. They are using electronic medical record EMR, and they're using, I'm going to say, you can say it a science or evidence-based medicine or recommended care. Because as you know, there's variation of how a certain physician treats diabetes in Temple versus a physician treats diabetes in San Antonio. We don't all, as physicians, follow a certain recommended care. In a patient-centered medical home, it is important that we agree and all of us within the community develop recommended care for a certain disease. So when we do this, we have to track our orders, and we have to educate the patient about their disease. And here we need to hopefully result in better care. So we ensure that the patient has access to the clinic. They get in. When they get in, the physician uses electronic medical record. And the importance of electronic medical record, because physicians are dealing with multiple variables within 10-15 minutes. There's no human mind that can remember all the information that we need to do in 15 minutes and apply them. So electronic medical record helps remind the physician, makes it easy on the physician to know what happened somewhere else. So make the information available at the point of care. And use recommended care. And when we do these things, we make sure that we're tracking what we're doing, educating the patients, and following care to make sure it's improving. So these are the 6 premises of patient-centered medical home: access, EMR, recommended care, track, lab test, educate the patient, and make sure it's getting better. I'm open for questions. It's a very good question. The question is this a gatekeeper like we have in the 80s? It is similar to what happened in the 80s, 90s, but it's much better. I think we learned from the mistakes that happened at that time. In the past, insurance company used to say to the doctors, I'm going to give you $100,000. You take care of the patients. And that's it. End of the story. They did not put any expectations on the doctors. And that system incentivized doctors to do less. And that's why we don't like that. That's why the gatekeeper, that I'm going to lock you in this area, and if I did not provide care, I'm going to win. This is different. This is saying to the doctors that if you're able to take care of the patient and prevent hospitalization, improve preventive medicine, avoid duplication of tests, we can decrease the cost of the care of this patient population, and you have to show me that the numbers are better in the quality of care here. If you can do both of these and you save some money, we can share that money between you and us. So it's not a gatekeeper model. This one is based on physician decision. One of the difference is that the previous model in the 80s and the 90s was driven by administration. People who are not physicians, here they're saying, go back, let the physician make the best decision for the patient. In a primary care setting, yes, because he's the one, he or she is going to be the person coordinating your care. You can, but you have to ask your primary care physician first. It depends on your insurance. It's not a limited network. And again, this is multiple options. In an HMO patient-centered medical home, yes, you have to ask your physician and insurance. But there are patient-centered medical homes that are based on PPO, which means you still have your patient-centered medical home, your physician, but you can choose your specialist. And it's an insurance differences. And that one did not change. You have to inform your primary care physicians. Yes, even in PO, because the primary care physician's best interest is to look at who is the best specialist providing care. For example, if a primary care physician knows that the specialist is not providing the care that's needed for the patient in terms of heart disease, diabetes, the primary care physician can speak with the patient and make an informed decision about choosing another. I don't think it's going to get to a point that I force you to go somebody else. And this was about engaging patient education, that the decisions need to be made together in the best interest of the patient. And I anticipate
with the patient
and with their family to make the best decision for the patient. Yes. Thank you. Another question.
I'm sorry, I didn't understand her caveat. What did she say?
She's saying that when we make decision to change a specialist, this is decision done between the physician and the patient together. It's a joint decision. Is that what you're trying to say?
Yes.
Okay. Currently, there are multiple options in Medicare. We have the fee-for-service, which is the old model. Medicare is telling us that this is going to shrink, it's going to change over time. Medicare gives options for our clinic to do something called MSSP, Medicare Shared Saving Program, and this information is available on the website, in which we can continue the fee-for-service, but it will incentivize physicians to prevent emergency room visits, prevent hospitalization, keep the patient healthy, keep the patient satisfied. So there are incentives in that system to keep the patient healthy. The third option is Medicare Advantage, which is the other end of the fee-for-service. In medicine, you can think of it as art and science. Around the science in medicine have been gradually increasing over years. So if you go back to the 70s and 80s, most of medicine was as an art. You go and you learn and you become the professional, you make a judgment on what your professor told you and your experience. These are the two sources. Now healthcare is moving into more science, which means you make your decision based on what the evidence tells you. And that's where the physician have to decide between art and science. So we apply the evidence, medicine recommendation, what's the best practices, but eventually it's between the patient and the doctor to make the decision. Did that answer your question?
So the doctor can go outside the recommended care and do something else for you?
If the recommended care was not done and it's in the best interest of the patient, talking with the patient again, informed decision, yes. So the question is, would Medicare pay the doctor based on the quality that the physician is providing? So the model right now is the fee-for-service, which means the Medicare pays irrespective of the result, is moving toward more for quality. And they're saying that, for example, the Medicare Shared Saving Program, it will give a certain clinic or a group of doctors, 50,000 patients, will say, we're going to continue paying you per service, but if you improve the quality, and these are the quality measures we want you to achieve, and if you were able to cut down on the waste, the unnecessary test, you can get some of that money that you're saving. But you will not get that money if you did not show that there's a quality improvement. And this quality improvement set usually by Medicare, but we also see it with commercial insurance. So now United is coming to us with the same discussion, Humana, Blue Cross Blue Shield. So it's not just Medicare. Commercial insurance are coming to tell us, if you can save, if you can prevent unnecessary care, emergency room visits, a duplication of tests, we will give you back some of that money on one condition, if the quality of care has met these criteria, A, B, C, D. And that's the difference between the 1980s and now. Okay, so there's two questions. There's a problem at the national level. I'm going to repeat your question. Problem at the national level with shortage of primary care physicians. And you're asking about what physicians do we have in the clinic. Let me answer the quick one first. In our clinic, we have both family medicine and internal medicine physicians. And we are trying our best to expand the primary care, knowing that this is what the population needs and wants. Going back to your initial questions, we do have a shortage in the primary care. Two comments. The Affordable Care Act provided coverage, more coverage to the uninsured, but really coverage does not mean access, because if you have coverage, if somebody has insurance, does not mean they have access to a physician. So what's happening right now, there's a white paper that went to Congress a few weeks ago in February, and the Congress is going to vote on it by the end of this year. It's the changes in the SGR. SGR is Sustainable Growth Rate. It's a formula in which Medicare pays the physician, and it's going to change to pay primary care physician more over the next 4 years to encourage more medical students to go into primary care. And the other solution is that some of the clinics, and we may go into this route, primary care physicians or practices, they're hiring more mid-level providers and ask them to take care of the problems at the level of the mid-level providers, nurse practitioners and PAs. And that, historically, looking at other clinics, has done very well without jeopardizing the care for the patients. She's asking why ADC does not accept Medicare Advantage insurance. And my response to her is that we are actively looking at that, and it may change soon. And it's mostly because Medicare Advantage that's available in Austin right now, it's through Humana. This is one of the most prevalent program. So we are in active discussion with Humana about that.
United Healthcare also.
It does, yes, it does.
But you're not talking.
Not with United about Medicare Advantage, no. But you may see some changes in the future.
But what difference is there between these programs if they would say we don't take that? I mean, what is it that they are objecting?
And partially it's, I think, on both sides. Partially is how they want things to be done, and partially that we are growing to provide the care for Medicare Advantage. With an episodic care, the clinics at a certain point cannot provide the Medicare Advantage kind of services. With us building the patient-centered medical home, we're becoming stronger and better in providing the care that meets the Medicare Advantage needs. And that's why I'm saying this is a parallel. We are growing, and we're talking with the insurance companies.